Okay. Okay, welcome everyone. Hello and welcome to this afternoon session, Facilitating Safety and Managing Complexity. So my name's Dr. Kate Buchanan and I'm from University of Notre Dame in Fremantle, Western Australia. And I'd like to thank the Balinese people for hosting us here for this wonderful conference and the ICM. So without any further ado, we'll go ahead and introduce our first speaker. And the title of it is, Why Don't Pregnant Women Follow Guidelines on Consumption of Important Dietary Sources of Iodine? A Quantitative Pilot Study. And it's my pleasure to invite up here PhD student Bjorn Bjorg Christian Duarte, and she works in antenatal care. So please come up.
Nice to see you. I would like to thank the Conference Scientific Board for this opportunity to present our study, Why Do Pregnant Women Not Follow Guidelines on Consumption of Important Dietary Sources of Iodine. My name is Þórdís Björg Kristjánsdóttir, and I'm a Master in Midwifery from the University of Iceland. I work in maternity care, in healthcare center, and I work in midwife's home service and assist with home births. My co-authors on this study are Dr. Berglind Halldórsdóttir, midwife, and Dr. Ingibjörg Gunnarsdóttir, nutritionist. Oops. I would like to begin the presentation by telling you a little bit about Iceland. The Icelandic people are a small nation, about 388,000, living on a relatively large island in the middle of the Atlantic Ocean, with harsh terrain and unpredictable weather. The social standard of education and living are high, and the country ranks high in gender equality. The number of births each year in Iceland is approximately 4,300. In previous years, Iceland was an agricultural and fishing nation, and the population ate a lot of fish and dairy products. But now, a recent Icelandic study has shown that women of childbearing age are iodine deficient due to low consumption of fish and dairy products. Iodine plays an important role during pregnancy for normal growth, development, and the metabolism of the fetus. Iodine deficiency during pregnancy is important to prevent in order to avoid serious negative impact on the physical and mental development of the fetus. The need for iodine consumption increases during pregnancy, and it is estimated to be 50% higher than in women that are not pregnant. According to the World Health Organization, iodine deficiency is considered to be one of the biggest nutritional problems in the world and the single biggest problem when it comes to fetal brain development. This has been dealt with, among other things, by iodizing salt in many parts of the world. There are not many types of food that contain iodine, and therefore it is important to consume these foods regularly and in the amount suggested in diet-related recommendations. It is recommended to eat fish 2 to 3 times a week, preferably lean fish, such as haddock and cod. Lean fish contains more iodine than oily fish, like salmon and char. It is recommended to eat dairy food 1 to 2 a day, but cheese is not included because it does not contain as much iodine as other dairy products, like drinking milk and fermented dairy products. It is well known that the consumption of fish, milk and dairy products is linked to iodine status in individuals, as these foods are known to be good sources of iodine. Iodine deficiency was recently observed for the first time in Iceland among pregnant women, most likely due to lower fish and dairy consumption when compared to previous studies. Little is known about women's attitudes towards fish and milk consumption and why they consume these foods to a lesser extent than before. The aim of the study was to examine why pregnant women do not consume food items that are important sources of iodine. The purpose was to support midwives' informative role in prenatal care. The research method was a quantitative cross-sectional pilot study. The study was conducted at the end of the year 2019. 100 pregnant women receiving prenatal care agreed to participate. Women answered a questionnaire through a telephone interview on consumption of fish, dairy, and supplements containing iodine. The results were compared with the food-based dietary guidelines from the Icelandic Directorate of Health. Women with less than the recommended consumption were asked about the reason for not consuming more fish and dairy. A list of questions was used, divided into 4 parts, a total of 16 questions. In the first part, there were questions about consumption of dairy products. In the second part, there were questions about fish consumption and what types of fish they ate. In the third part, the women were asked about the consumption of food supplements. In the fourth part, they were asked about their background. The percentage of women claiming they never consumed dairy was 13%, and 27% consumed 2 or more portions a day in line with food-based dietary guidelines. Women who never used dairy products for a maximum of 1 serving per day were asked about the reason for not consuming these foods more often. Various explanations were given for not following the guidelines on dairy consumption. For example, 14% of the women said that they did not like dairy products, and 24% gave no specific reason for not consuming dairy products. The percentage of women who said they never consume fish was 9%, and only 27% consume fish 2 or more often times a week. Women who ate fish once a week or less were asked about the reason for not eating fish more often. There were various reasons given for not following the guidelines on fish consumption, but 10% of the women said they do not like fish, and 18% gave no reason. 15% mentioned that they only ate fish at work, didn't cook at home, fish at home. Even though 97% of the women took supplements, only 7% of them took supplements that contains iodine. Based on the number of people who do not reach the criteria for the consumption of dairy products and fish, according to the Office of the National Medical Examiner, more women in Iceland would need to take supplement that contains iodine. Based on the results that about 40% of those who use dairy products once a day or less, and almost 33% who consumed fish only once a week or less, had no reason why they did not consume these foods more often, it is important to increase education in maternity care about the importance of consuming foods that are good sources of iodine. It is important to advise women who cannot increase their intake of fish and dairy products to take food supplement containing iodine. It is recommended to take 150 microgram daily. Then there is a group of women who have intolerance, allergies, are vegetarians or are vegans, who also need to be considered because they are at risk of not meeting their iodine needs during pregnancy. Midwives are in a key position to provide education to pregnant women because women come to them regularly for antenatal checkups. It is therefore important to ensure that all midwives have knowledge of the importance of iodine and provide such education. Along with this study, there was a lot of discussion and education for the public. Drawing attention to the importance of iodine during pregnancy. Training for midwives was also started, and they were strengthened to provide this training to expectant mothers in maternity care. There has been a great awakening in a very short time, and more people in Iceland are aware of the importance of iodine intake in the form of food or supplements. Thank you. Oops. Sorry. Thank you.
So we've been asked to leave questions for everyone till after we've gone through everyone's presentation. So next I'll invite to come and speak Professor Venora Hundley from the United Kingdom, Bournemouth University, and she's going to be sharing on the importance of taking pain histories for the latent phase of labour. If you could welcome her up. Thank you.
Thank you so much for having me here to tell you a little bit about our work. It's a delight to be able to present to such an international audience and to have the opportunity to share some of the things that we've been doing. As Kate said, I'm Professor Venora Hundley. I'm Professor of Midwifery at Bournemouth University. But this work is not on my own. This is a collaborative piece of work. I'm pulling together two pieces that we've done recently. The first piece of work that I'm going to be talking about is around pain catastrophization and looking at the prevalence of pain catastrophization in a young, non-pregnant population. And that was led by Professor Carol Clark, who's a professor of physiotherapy at Bournemouth University. And it had our colleagues, two students, Gusta and Vanessa, and Professor Helen Chain from Stirling University. And then we also have just published some work, again, similar group, but also with Dr. Dominique Mylloyd, who's been at Bournemouth University. So we've been looking at pain history. So this brings this all together with regard to the latent phase. So I've been working in the area of latent phase labour for a number of years. We've done a number of studies looking at how we support women. Most of that has been involved changing practice, changing services, to look at how we can support women at home to ensure that they come into hospital in active labour. But I'm interested in how we can look at women-centred services. So to begin, we wanted to look at really what is the latent stage of labour, and I was involved with the intrapartum care for a positive approach to childbirth experience, where we looked at a variety of aspects of labour and looked at the definition for latent phase of labour. And the definition that we came up with was that it was characterised as painful uterine contractions, variable changes in the cervix, including some degree of effacement, and slow progress up to a dilation of 5 centimetres for first and subsequent labours. But we know from looking at the literature that it varies considerably across the world and even within countries. And that makes it really challenging for women, especially when they need to know, are they 5 centimetres or more to come into hospital? And what we want to try and avoid is this slippery slope or cascade of intervention, because the literature is really clear that when women come in the latent phase of labour, they get into this cascade. And we're not quite sure why. It's possibly because as midwives and healthcare professionals, we're not actually that good at sitting on our hands and waiting. But also we know that women themselves feel that time is going on and things should be happening. And so what happens when women come in that early labour, that latent phase, is that they end up with more interventions. They're more likely to have electronic monitoring that reduces their mobility. They're more likely to feel pain. They need more analgesia. And that results in needs for augmentation and subsequently either a caesarean section or an assisted birth. So why do women come in that early stage? Well, we know that there is a mismatch between what women experience and report as latent phase or labour onset and the way that we as midwives anticipate or to expect it to happen. And that results in differences in diagnosis and inaccurate decision making. Women who seek early hospital admission may have heightened fear and anxiety in relation to pain. And what we hypothesize is that anxiety might actually be rooted in a pre-pregnancy experience. To understand that, we need to ask them about their pain when we do the booking appointment. Pain histories are actually something that's really quite common in other areas. So working with my colleague Carol Clark, who does a lot of work around chronic pain, chronic back pain as a physiotherapist, it's one of the first things that they would ask people is, what is your pain history and how does that influence you in relation to how you anticipate pain? What we know is that there are a number of different determinants of pain. Obviously, the biological determinants are there, but the way people perceive pain is affected by both their psychological and their sociological experiences. So we know, for example, that pain beliefs or anxiety can relate to how people perceive pain, but also their family and the people around them can influence that as well. Feelings of fear and anxiety based on previous experiences, memories, or beliefs can lead to an avoidance of activities, including future events. So those of you that were fortunate enough to have the yoga session prior to starting the conference, we heard from the physiotherapist there about how, you get up, you feel your back's a bit sore, so you don't want to move, but actually what you need to do is you need to move. And so that fear can stop you doing that. And we know there's some evidence of that in relation to pregnancy, where fear of pain has been associated with maternal request to avoid labour and to opt for a caesarean section. Often that may happen quite late in the pregnancy, and so our aim is to look at how taking a pain history and using this information can help us to plan ahead. Occasionally, fear of pain can become a constant worry. It's coupled with negative thoughts relating to pain and a sense of helplessness. And that is known as what's called pain catastrophization. And it has been found to a limited degree to influence what women experience in terms of labour pain. So knowing whether women pain catastrophize could be a valuable part of history taking. So we set out to really identify the incidence of, or prevalence rather, of pain catastrophizing in a healthy, non-pregnant population, and to try and identify the characteristics that could predict pain catastrophizing prior to pregnancy. This was a small prospective observational study. We had 122 undergraduate women of the age between 18 to 23 at two universities, one in Scotland and one in England. We asked them to complete a semi-structured survey which had 4 validated tools. The first of those was the Childbirth Fear Prior to Pregnancy Scale, which is a tool that is used to look at fear of childbirth in women that have not experienced pregnancy before. The second was Fear of Pain Questionnaire. It's been used fairly widely and is a well-validated tool. The third one is the PAS-20, which is Pain Anxiety Symptoms Scale. And then the PCS is the Pain Catastrophizing Scale, and that we were looking at to see what the prevalence of pain catastrophizing is. In addition to our descriptive statistics, we run some correlations and a multiple linear regression to explore the predictive factors that influence or correlate with pain catastrophizing. So first of all, to have a look at the pain catastrophizing scale. And it's made up of these 3 areas. The first of those is rumination. So that's where something's going on in your head and you just can't get it out. You just keep thinking about it and worrying about pain. I can't seem to get it out of my mind. The second area in the PCS is magnification, thinking where something really serious will happen. This pain's causing me harm, it's damaging me, I shouldn't have it, it's really serious, and I'm worrying about that. And then the third aspect relates to helplessness. You know, I'm worrying about it all the time, there's nothing I can do, I don't know how it's going to get better, I don't know how I can cope. And so those 3 areas make up this total PCS score, which was what we were interested in. And you'll see that the average score was 20.36, but with a really quite a wide range within there. In the literature, there are 2 cutoffs cited. The first of those by Fink et al., and this has been looked at with regard to pregnancy. The cutoff is at 20. And you can see we were really surprised to find that a large proportion of our undergraduate students had a pain catastrophizing score of over 20. So that's 47.5%, which is quite a significant number, or quite a large number. Sullivan uses a more conservative effort. He says 30 is a reasonable number, and we had nearly a quarter of the group. So it was quite high, but obviously this was an observational study. Women could self-refer to it, so perhaps we had a slightly biased group who were interested in pain. From the correlations, pain catastrophizing was correlated with both fear of pain and pain-related anxiety. However, it was not correlated with fear of childbirth, nor was it correlated with age. The multiple linear regression confirmed that fear of pain and pain anxiety were significant predictors of pain catastrophizing. So what does that mean? What can we do with this information? Well, as I've already said, pain histories are not something that we use very often in maternity at the moment. So why don't we ask women about this? Why don't we see what the prevalence is? We could actually use this pain catastrophizing as a screening tool, because we know that fear of childbirth is associated with higher intervention. But actually, when we look at fear of childbirth through pregnancy, it often doesn't become apparent until the 3rd trimester. And by that time, you're thinking, well, what can I do to support this woman? Early work, we've got a study going on at the minute, which Vanessa Bartholomew, one of our doctoral students, is looking at in women in pregnancy. And early work suggests that pain catastrophizing score is associated with fear of childbirth. Now, the PCS, we know, is there pre-pregnancy, but also at booking. So it could be a screening tool for help us to identify those women that need additional support and additional conversations prior to labour. We would like to propose a model, and this is what Vanessa is testing at the moment, in which at the centre is your previous pain experience. So this is very much based on the fear avoidance model that's used in physiotherapy. At the centre of the model is the fear of pain, your previous experience. If you have no fear of pain, then you go around the right-hand side of the model. So women who don't have fear of pain may be quite happy in the latent phase of labour. They remain at home in familiar surroundings. They manage to self-manage their pain. And one would hope they would have a physiological birth. Those women who pain catastrophize would go around that left-hand side of the model. Their fear of pain might lead them to come in early to the hospital. That puts them in an unfamiliar environment. It raises their anxiety and it causes them more fear. And that leads to the hypervigilance, increased intensity in fear, a loss of control, and perhaps a need for more intervention. And it doesn't stop in this pregnancy. It can roll on and have implications for future pregnancy. So we're testing this at the minute, and hopefully Vanessa will come in 3 years' time and give you the results of that. But we're hoping that we will have, by using the pain catastrophizing scale, we can identify women early at booking, we can give them support, perhaps through a specific targeted program that might involve hypnosis, it might involve breathing, and that would reduce their likelihood of coming in a latent phase of labour and reduce that cascade of intervention. Thank you very much for listening.
I next invite to the stage Mary Mathengai from Kenya, and she is a midwife and also technical officer lead. And she's going to be giving the 3-minute thesis. Now, there's a real skill and art with giving your research in 3 minutes, and I would just like to let you know I'll be probably standing at the 1-minute mark and showing that red card. So it's really strict, but we wish you all the best with doing that.
Thank you very much and welcome for this session. I'm going to share learnings from Makueni County in Kenya. Sorry. Yeah. Can you remember this scenario? You are the midwife on duty. You get a call from a periphery site, 100 kilometers away. They have a mother with obstructed labor. They need cesarean section. As a midwife on duty, you inform the other colleagues and you are sure that everything will be done. The mother arrives 2 hours later. She's wheeled to theatre. On reaching theatre, you realize the anesthetist who was there has been called to trauma center. The medical officer who was supposed to do the operation is not there. And the nurse midwife who was supposed to receive the baby has 3 more mothers who are going to second stage. You start panicking. That was the scenario before we started the obstetric safe surgery program in Makueni County, which was funded by Johnson & Johnson. After training of these clinical teams, which were working each as a silo, and there was no communication between various departments, we realized that there was the utilization of the surgical safety checklist and the correct use, because it moved from 0 to 96% adherence and utilization. Then there was the use of infection prevention bundles, the 3 bundles. We have the pre-op antibiotics. We have the vaginal cleansing, which was done in any facility. And we have the abdominal skin prep, which was done anyhowly, because there was no standardization of knowledge and skills to these midwives and the officers who are doing the cesarean section. This is a routine practice in our county now. Then the anesthesia technique. The mothers were being verbalized so that they can hold on the pain. But now we know we have to give them at least an anesthesia so that they cannot feel the pain. Before you do that, you give them the anesthesia. Then we use the hub-and-spoke model, and where we have the mentors, where the clinical team mentors other people from the periphery sites, and the perioperative continuum of care, where we track the mother-baby pair on the 7th and the 3rd day for surgical site infection, and our surgical site infection have decreased by 50%. The initiation of breastfeeding at theater on the operating table has moved from 28% to 84%. Then we have done the delayed cord clamping within 1 minute. For this, everybody was in a rush to give the mother to the midwife, all to take them to labor ward. But that is not the case. They are delaying for 1 minute, and this is beneficial to this baby. These are our learnings, and obstetric safe surgery, the midwife is the anchor. Because when you are not there, nothing can run smoothly. You are very key to this. Thank you very much.
Wow, well done. 3 minutes, that was incredible. Okay, so next we have our speaker, who is a senior expert for the Finnish Institute of Health and Social Welfare, and it's Mimi Kukula from Finland, and she is sharing on female genital mutilation, cutting, among women giving birth, preventative actions and care of survivors in Finland. Thank you.
Thank you. Where should I take it? Okay, good afternoon, dear midwives. So nice to be here. I come from Finland, Finnish Institute for Health and Welfare, and I'm a midwife. I've been working in a maternity hospital over 10 years, and now I'm working as a senior expert with FGM issue in Finland. We have a national coordinating role in Finland on the work against FGM. And Reija Klemetti from DHL, from the same institute, has been doing this presentation with me. And Finland is situated in the northern Europe. We are a small country also. We have a population of 5.5 million. And we have had increase of the size of the migrant population in Finland also during the last 30 years. Now we have about 8.5% migrant population. So not very big compared to other European countries maybe, but still it's been growing. And we also have had growing number of migrants with origin in countries where FGM is practiced. For example, Iraq, Somalia, and Afghanistan. And in this presentation, I have 3 parts. I will a little bit talk about the background of FGMC and also tell a little bit about my research, as I'm a PhD student also making my study on FGMC. And then we will talk a little bit about midwives' role in preventing and taking care of FGMC survivors. But first about the background of FGMC. WHO defines FGMC as a traditional harmful practice that involves removal of external female genitalia or other injury to female genital organs for non-medical reasons. And it's a form of honor-related violence and also gender-based violence. And often there is an aim to restore girls' honor and reputation behind the practice. It is a violation of human rights and also prohibited by law in many countries, also in Finland. And it is usually carried out on young girls between infancy to 15 years, most commonly before puberty starts. And we still have limited information on the prevalence and adverse health effects of FGMC globally and also in Finland. Here are the 4 different types of FGMC as WHO defines it. Also the pictures of these types. Type 3 is the most severe one. It can be also called infibulation or pharaonic circumcision. And type 1 and type 4 are the smallest types. But still, also those types can have serious effects on well-being. There are about 200 million girls living and women living with FGMC at the moment, and 4 million girls are in risk. And the prevalence or the countries where FGM is mostly carried out are concentrated on the African countries, in the Middle East, and also Indonesia has nearly 50% prevalence of FGMC. But it's still important to remember that also in other countries it happens, and there can be women and girls affected by FGMC. And we know that FGMC causes a wide range of physical and psychological health problems. Immediately after the procedure, there can be pain, bleeding, urinary problems, infections, and different psychological symptoms. And also long-term, same effects, but also consequences of scarring, retention of menstrual blood, fear and pain of intercourse, orgasm problems, different neuromas, keloids, and those scarring problems, and even infertility. And FGM can also cause harm during childbirth. There can be postpartum hemorrhage, tears and lacerations, cesarean sections, instrumental childbirth, and prolonged labor, episiotomies, for example. And also babies, newborns, can be affected. And it's important not to forget the psychological harms of FGMC. They can vary from sleeping disorders and fear, even to depression and post-traumatic stress disorder. And now we go to that study part. I'm going to talk about a little bit this ongoing study. Purpose of the study is to find out what is the prevalence of FGMC among women giving birth in Finland, and what kind of health harms does FGMC cause to women and their newborns during pregnancy and birth. And the method is a descriptive population-based register study. And the data were obtained from the Finnish Medical Birth Register from the years 2017 to 2021. And this Finnish Medical Birth Register, it registers all the mothers and infants born in Finland up to the age of 7 days. And its purpose is to collect statistical data for the research, development, and provision of maternity care and obstetric services and the care of newborn infants. And it has included a question about FGMC since 2017. And actually midwives have a very central role in collecting the data to this register. So it's very important that we get tick on the box every time there is a some woman delivering with FGMC. And in this slide you can see the amount of births in Finland. Annually we have around 45,000 to 50,000 deliveries, and the prevalence of FGMC has been there around 0.2 to 0.5%. Quite low, but still a little bit less than 200 females normally, annually. And defibrillation numbers, they are quite small here, as we have just, I think the professionals are not yet so aware that how to collect the data on defibrillations also. So actually I believe the real number is bigger than these figures, but this is a little bit giving some idea that it's done. And the most common countries of origin of the females with FGM are from Somalia, Afghanistan, and Egypt in Finland. And then here are about the birth outcomes. We have looked at third and fourth degree tears. You can see with the yellow I have marked. It seems that mothers with FGM, they have a little bit higher risk also for third and fourth degree tears. Also the same with vacuum extraction, but then on elective caesarean sections, it's vice versa, that mothers with FGMC, they have a little bit lower incidence of caesareans. But then on emergency caesarean sections, it's again so that females with FGMC, they have higher amounts of emergency caesareans. But these are just preliminary results. I don't have yet more to tell about these ones, but we will be writing then an article, and then there will be more information on these. But then I still want to say a few words about midwives' role in prevention and care of FGMC. In Finland, we follow the Istanbul Convention, and it's guiding the work against FGMC. We have an action plan for the prevention of female genital mutilation, and we've been yeah, the action plan has been for 4 years now, and we've been coordinating the work to do it. And the aim is to secure the training and increase knowledge and expertise of professionals and decision makers who encounter FGMC in their work. And it's also important to increase knowledge of the harmful consequences, legislative framework, and benefits of abandoning FGMC, also on the communities originating from the countries of FGMC practicing countries. We have, for example, made this kind of instructions on reconstructive surgery after FGMC for members of communities with Somali background. And together with Somali background workers, we have made it in Finnish and in Somali language, and it's been taken quite well in the community, because it's not only from the national board or institute, but it's from the grassroots coming straight to them. Then we aim to create a permanent national and regional structures to prevent FGMC and to provide care and help for the girls and women living with FGMC. And this national action plan also includes specific instructions for midwives, and then it's also very important that midwives know the content of the guidelines to be able to implement the good practices. We have this kind of guidelines, what to do if there is a suspected case, and, for example, clinical pathways of a pregnant woman who has undergone FGMC. And if we think about the care of FGMC survivors, it should be very women-centered and right-based, and respecting the wishes of a woman. And also all the individual needs should be listened to, and respecting the autonomy of a woman. FGMC should be brought up in the discussion on the very first visit. It can be during pregnancy or already earlier. And if it's talked about during pregnancy, then it's important, or if it's found out that she has a FGMC, then making a birth plan is very important, and also the referral to hospital early enough. So the delivering hospital will also be aware of the FGMC. Care should be trauma-informed, and also the physical symptoms should be treated well. Defibrillation and also the reconstructive surgery are available in Finland, and we are also trying to get more information to the professionals about the reconstructive surgery, because it's not so well known yet. But also important is the psychological support before and after these treatments. psychological therapies, cognitive behavioral therapy should be offered, and psychophysical physiotherapy also. And sexuality education is very important. Counseling, sexual therapy, what is needed, it should be offered. And also, not to forget the husband or partner. Also, peer support is important, and conversational discussion groups, I mean. And then again, supporting the change in attitudes of the practicing communities is very important. Giving information about the harms of FGMC, human rights, legislation on each country, and especially the postpartum period is very fruitful for advocating against FGMC, as there is if there is, for example, girl child, then it's a very good moment to talk about FGMC and about the practice. Okay, as a conclusion, I would say that midwives play a very central role in identifying FGMC and also recording the information up. It can be a birth register or what kind of each country ever has, but also to the patient records. So it doesn't, or the information follows the mother. And with the routinely collected data on FGMC, it is possible to get better understanding of the prevalence of the phenomenon. And also it helps to guide the preventive work properly. And also midwives provide care and support for survivors of FGMC before, during and after childbirth. And they also share the information about the disadvantages of the tradition to safeguard girls' children. And it's very important to ensure that training and availability of guidelines is there to increase the knowledge and expertise of professionals. Thank you.
Okay, and our final speaker for this afternoon session, we have Camilla Main coming up to share her presentation on giving birth without fear, a Swedish method of ensuring an emotionally safe birth, and I'll let her share her bio. Thank you.
We're good? Haven't broken it? Okay, good. Hi, everyone. Thanks so much for coming to this session. I hope you're all warm enough. It's quite cold in here, isn't it? So I'm a midwife. I have two completely different hats. One, I'm a lead midwife for London Ambulance Service in the UK. And my other hat, which is where I am here today, I'm a midwife, a non-ambulance trust midwife. And I work with the team in the UK that have very recently adopted this method from Sweden. So the founder of this method was supposed to be here but can't be here. So I very much have imposter syndrome and should not be presenting this. But thank you for having me. So this is very much an introduction to this method. This is a very specific method that's been developed using multitudes of research from many years, from many countries, much of which probably you've all been involved in that research that has fueled this method. So the Give Birth Without Fear method, and the give is important because there's another company called Birth Without Fear. This is Give Birth Without Fear. It was developed by Susanna Healy. And it really started off as a childbirth education method, but it's developed into some other things, and there's also a model for healthcare systems to adopt as well. And recently the Swedish book has been translated into English, and hopefully that is going to develop into other languages, many other languages as well. So there's two kind of components for the women and for the healthcare model. And the two together work really nicely together. So just before we do that, I'll just tell you that there's over 50 hospitals in Sweden that use this method. In the UK, we're like before embryonic, whatever that stage is. But Sweden would be like a 3-month-old baby, you know, in comparison. So this method, it really acknowledges the fact that birth is not just a physical event. And yes, it's important that mum and baby get through birth physically okay, but that's not the only important thing. They need to get through birth emotionally safe and psychologically intact as well. And we know that whilst women are giving birth, they very much engage their thoughts and feelings. And it's normal to have a certain level of fear due to the fact that birth is so uncertain, right? So women might feel fearful because of a previous birth experience, or because they're worried about intervention, or nowadays because they've seen on social media all the birth horrendous things that can happen. They might be worried about giving birth in front of their partner, worried about pooing, worried about the pain. There's many reasons why a woman could feel fearful, and a certain level of fear is normal. But what we know about fear is that it not only physiologically affects the birth by stopping the woman progressing, which you all know this anyway, but it kind of lays the foundation for the method. But also psychologically it can affect the birth. So we have this thing called nocebo, where if you, what research tells us is that if you expect to have a negative birth experience, you are more likely to have a negative birth experience. It's like a self-fulfilling prophecy, really. So we know that fear translates into that. And this method is really to help women deal and process that fear and reduce it, minimize it as much as possible before it affects the birth, either physiologically or psychologically. So it can be used to treat fear of birth antenatally, prevent secondary fear of birth, childbirth, and prevent PTSD, which we know is massively increasing. And in the UK, we have a massive problem with this. So we're really trying to empower these women to have an emotionally safe birth experience, not just a physically safe birth experience. So we want to bring these women from fear to confidence, and this method helps us to get there. So the method really is based on the foundation of salutogenesis. So women have an inherent ability to give birth. The body knows how to give birth. But what we know is that what can stop that is this stress and fear. And we all have this, non-pregnant as well. Everyone has a stress and fear system and a peace and calm system. So in the stress and fear system, adrenaline spikes, fight or flight. We need that system. If a lion is running across a park at us, it would be no good being in our peace and calm system. We need all the blood to run to our limbs so that we can run away from the lion. And if we're giving birth in that situation, it's a physiological no. Your body says, no, it's not safe to give birth right now. Blood runs away from the uterus to the limbs. We're ready to run away from the danger. And it's a negative spiral. The more adrenaline spikes, the more fear comes, and then more fear, more adrenaline, and we go down this negative spiral. But we also have this other great system, the peace and calm system, and when that's activated, we get this physiological yes, and the body is safe to give birth and relaxes into it, and we have this positive spiral, and as we know, the more positive we feel about something, that becomes the self-fulfilling prophecy. So essentially there's a line between fear and trust, and we want to move the woman and we're moving her along this line. We can't just pick her up from stress and fear and put her in trust and confidence. If only it was that easy. We need to move her along the line towards trust and confidence and activate the peace and calm system. And this is what the method is really based on. And so when we do move the woman away from the stress and fear system, what we do is elicit the oxytocin tap. And much cleverer people than me can tell you all about oxytocin, and you can read about that. This session isn't going to be about oxytocin, but obviously we can't do this session without mentioning oxytocin. And we know that it's a positive feedback mechanism as well. The more oxytocin you produce, the more you produce it, and it just keeps going. So if I now bring in the method, and this was really just an introduction to hours and hours of training that the method you need for the method. But I'm just going to talk through some components, if that's okay. I can see I've got 7 minutes. Okay. So if I'm going to start on the left-hand side here with the lighthouse. So for landlocked countries, just to explain, a lighthouse is the thing that goes near the rocks to stop the boats going on the rocks, yeah? So in this method, we see the lighthouse, the partner as the lighthouse. And that partner can be whoever is the trusted birth companion. So either their relationship partner, boyfriend, girlfriend, husband, wife, whoever, or it can be a sister, friend, whoever. So within the training, you very much train together, the woman and whoever's going to attend with her at the birth. And then obviously midwife as well within the healthcare model. So a lighthouse, the features of a lighthouse is that it's steady, it's standing there on the rocks and it's blinking, yeah? It just blinks and blinks and blinks. And it's the stability that the woman looks to. And we really train the partner about how to be that stable person. And what they say and what they do and how they touch the woman and how they press the woman and how close they stand to the woman will make an effect on how emotionally safe the birth is. And so the training of the lighthouse is really, really important. And they're preventing that woman coming onto the rocks which would be a fearful birth. And then there's the tools, which the lighthouse basically helps the woman to activate the tools. And there'll be different tools. They'll be trained to use the tools in different situations. So they will be taught to scan the body and scan the body language of the woman and then activate the right tool at the right time to help her go through the contractions. So I'm not going to go through all the different tools there. I don't think you can read it at the back, though. So I'll quickly mention a couple of things. I've got 5, yeah. So the breath is soft and silent breath with a sigh at the end of each contraction. Heavy is really about the muscles being really passive to this process. So we talk with heavy, it's very much about, if you're out at sea on a boat, on a surfboard, let's say. So you're on a surfboard and you need to ride the wave back to the shore, right? But you need to just let the wave take you back to shore. So that's what we need, this heaviness, this passiveness around birth so that we can kind of melt into the process. We'll come back to that. The sound is a very deep sound. And then a lot of it is about the psychology of getting through the contraction. So physiological, yes. And literally saying, yes, I can do it, those kind of positive affirmations. And there's certain things that we train the partners around saying or not saying. In terms of the contraction, so you'll notice, I don't know about other countries, but in the UK we always draw contractions as like mountains, yeah, that you need to get over. So in the method, we changed it to like the rest between the contraction is the highlight. And then we go down, because of gravity, we need to go down as well into the contraction. And we ride the wave back up out of the contraction. And it's really about diving into your body and surrendering to the process. And a lot of the training is around surrendering to the process because it's the fighting of the process that can then perpetuate the fear. So this is the healthcare book, which I don't have time to cover at the moment. So I'm just going to move on from that. There is a stress and fear evaluation model, which also you can look up in your own time. And that is very much about training the midwives so that they can work together with the midwives, doctors as well, very much are trained in this. And the healthcare model, it also brings in this contact, assess, action. So also they're scanning the body for the emotional safety at which the woman is in, and that gets handed over as part of the midwife-to-midwife handover. So that we can make sure, even if they don't have continuity of carer, that they continue to support this woman's emotionally during her birth. And then I just want to finish on highlighting this. So this was released about 10 days ago now. You can all download it. It's fully active in Swedish. So if you speak Swedish, brilliant. The English version should be launching shortly. So when you register, there's on the top left, you just need to change it between Swedish and English. And then other languages will be added soon. And if anyone wants to be involved in translation, then we would love to hear from you. So this is the early labour app is based on the fact that 1 in 3 primips have a latent phase over 18 hours. They're often sent home. We've heard it from the brilliant presenter earlier, all about latent phase and how it can affect women. But this is when the stress and fear zone sets in early labour for lots of primips. And so this is a digital support tool. It's been researched and re-researched over a number of years. And there's a randomised controlled trial that's about to start, which is around having a control group and then having the people using this and then having a blended method where they have this and support from a midwife so that we can develop the app even further. I would really highly recommend that you take a look at it. But essentially, the app embeds the method the method is embedded into the app. So that women can have that support at 2 a.m. when they're in the early phase of labour and they're not in the hospital. They can be already moving from the stress and fear zone to the trust and confidence zone. In conclusion, I would just say that a woman can have a great birth on paper, but leave the birth physiologically scarred. And so I think we all have a duty to make sure that doesn't happen. And we need to be intentional about this not happening. And the method helps us to be intentional about that. And what we know is that emotionally safe birth basically hands the woman a ticket to empowered motherhood. And that's why it's important. And the ticket says you can do it, you're enough, you're strong. And that's why it's so important that we all work together to make sure that birth is emotionally as well as physically safe. Thank you so much.
Hello, can you hear me? Yes, on this one. Great. Thank you so much to all our esteemed speakers and presenters today. They were wonderful and informative sessions. And we now have about 15 to 20 minutes of question time. So if you do have a question, just direct it to who it is and speak into the microphone in the centre of the room. So we'll start with questions now. Did anyone have any questions? We could start with Bjordis, with her presentation on iodine. Was there any questions? Yes, lovely.
Thank you. Thanks to all presenters. But, sorry.
Do you mind going into the middle microphone? Thank you.
Can you hear me? Oh, yes. Okay, I need to. For the first time, I have to actually make myself shorter. Thank you all, but I really enjoyed your talk, Camilla. I think it's fascinating. It's absolutely amazing to have some sort of support to address women's fear, because it's a reality. I was interested in knowing, I'm sorry if I missed it, has it been evaluated in the sense of seeing how they're actually reducing the fear? Do we have data on its outcomes? Has it reduced the risk of C-section, for example? Because it's something that obviously I'm hoping, I'm sure you've got objectives from this. So how has it been evaluated, please?
Is this working? Yeah. Thank you for the question. So my understanding is that the Swedish hospitals very much have great data on this, and that's why they're all adopting it, is because it works. In terms of pain relief, in terms of complaints, in terms of women's fear of childbirth, asking for caesarean section following a vaginal birth the first time, things like that. The actual write-up of all of that data hasn't happened, but yes, you're right, it needs to happen. Because we know that it's working, and that's why it's spread so far, and that's why we're adopting it in the UK as well. Oh, well, we're at the start, but we're going to try.
Thank you. I'd be interested to see the results if they're anywhere. It'd be good to pass it on.
Yeah, there are 2 studies that from Sweden regarding this tool that are out. But they don't. It's not so far. The whole mapping hasn't been done, but there is a study that shows that it reduces fear in lots of different ways, and there's lots of primary and secondary outcomes. So if you the birthbyheart.com, if you are interested in that study, if you go on there, you can find it on the website.
Thank
so it's
you.
birthbyheart.com.
Thank you very much.
Okay, well, I've got a question for you regarding the iodine study. So you did a quantitative research, and yet you gathered a lot of data using qualitative interviews on the telephone. I wondered what you might be doing with that qualitative data, and does it give you extra insight and add something that maybe the quantitative study didn't quite catch, or was there something you could glean from the qualitative data?
I didn't hear your question. Can you?
So you did a quantitative study and you did telephone interviews. Could you use some of that data that you had, like, because they would have been quite long interviews, no, or were they short? Yeah, was it just tick box? Yeah, sometimes a mixed method study can solidify your quantitative results and be strengthened with qualitative. So I was just interested, could you get anything else out of that qualitative data? I'm looking at your supervisor as well, because I thought. Yeah. Yeah. Yes, yeah. Interesting. Yeah, very good. Thank you. Wonderful. Thank you. Now, did anyone have any questions for Venora from her study on the importance of taking pain histories? That would be interesting for a lot of the midwives out there. We've probably all got an opinion on pain. So I wondered actually about, when taking a pain history, because we know that through relationship, women tend to then share more information with us. With your plan for taking a pain history, would you be revisiting it as time went on? Because again, in the very early parts of pregnancy, and again, culturally, a lot of women do conceal their pregnancies until quite late, like post either 12-week scan, 16-week scan. Would it be worth revisiting, those? Do you have some insights about that? Thank you.
I think that's a really good question. We're still at the really early stage of the study that we're looking at, but some of the work that we would do would be asking women when is the best time to do that, when to put in taking pain histories, but revisiting it once they've had a chance to think about it and think whether that is something that's coming up for them would be really important. What we're thinking, though, is that the pain catastrophizing scale could be something that's very simple to do at the booking visit, and in itself might open up those questions about pain history.
Okay, and our 3-minute thesis, that was wonderful. Yes. Did anyone have any questions for the 3-minute thesis? I mean, I really just had a comment. What excellent results you had. Yeah, I see you. What excellent. Oh, I'm losing my person. Come back. Have you got a question?
It was about the pain scale. If we're doing just some verbal histories and we're just talking to her about her past births or this coming one, what are just some good verbal questions that you would use to just kind of pry into any of that history, if you give suggestions?
So some of the things that are associated with pain catastrophizing are childhood experiences of pain. Dysmenorrhea is another one. If they've had, severe dysmenorrhea, how they feel about that. Those are the kind of things that are associated with pain catastrophizing, particularly in pregnancy. So those are the factors that, anxiety related to pain. So how do they feel about pain? Have they had a previous experience? How did they handle that? Those are the kind of things.
Okay. Thank you.
And then finally, were there any questions for Mimi on FGMC? Were there any questions at all, queries about that and the information provided? Well, this is probably a curly one, but cultural safety. It's really tricky, isn't it? Because you want to honour people's culture and then there's also then the law of the country. So I just wondered, did you have any insights or extra thoughts on that, or is that just too hard? Because it's a really tricky question.
Thanks. It is very, very tricky question, I think. But yes, still, I think that no culture can allow violence. So we need to see FGMC as a violence, and that way we can fight it. That's important, I think. And also right of the child.
Yes, lovely question.
I always have to bend for microphones, so this is absolutely a challenge. Mine's actually for Camilla, and I'm so sorry. I'm going to ask a difficult question, and I'm conscious I also work in London, so we're now going to bump into each other, and you can use this against me for the rest of our careers. I'm a midwife, but I'm researching around kind of technology and digital midwifery and things. And creating an app is notoriously great, but incredibly hard to maintain. The upkeep, the developing it, getting it out there costs, but then keeping it going, keeping it modern, keeping it compatible with phones is ongoing. What's your plan? And then can I steal it? Is that all right?
Where in London do you work?
I'm not telling you. Oh. No, I'm at UCL.
Brilliant. Okay, yeah, I'll share. Although they are north of the river, which is...
I know. Are you south?
Yeah.
Oh, dear. We'll have to have a fight on the way out.
Yeah, so we are really lucky. I mean, I'm saying we, like it's the royal we. I mean, this is not... I haven't done much for this at all, or anything. But what I do know is that the core team in Sweden is amazing, and they have a brilliant research team that are continually looking at the app and maintaining it. So there's the Susanna Healy has really cleverly funded this, and there's a strong business model behind the app. And so it's not like building an app in the NHS, is what I would say.
That was what I was alluding to.
Where there's no money. There's a really strong business model, which means that the researchers are properly funded, and the project team is really strong, and they're going for global domination with this app. Essentially, that's their vision, and they're putting their money where their mouth is, and so. The app is really evidence-based and is going to be continually updated. Yeah, sorry, it's not the answer that you need.
No, that's great. And I guess the research will prove that it's saving money, so I guess that's the answer, isn't it?
Yeah, exactly. So the pilot study has had brilliant results already, but based on the pilot study, the research team have already done lots and lots of tweaks. So the challenge is actually the translation element more than actually keeping the app up to date.
That's very helpful. Thank you so much.
No worries. See you in London.
And any final questions as we wrap up the session? It looks like there's another one. Thank you.
Hi, I'm Fleur from the Netherlands. I was wondering, the application is for the women in labor, but I think we need maybe the application for the lighthouse.
Yeah, so the app is for the lighthouse and the woman. Yeah, so they can both download it, and there's parts of it that speak to the lighthouse and parts that speak to the woman. Sorry, I didn't explain it properly.
Is that a question? Yes, lovely.
So, as you can tell by looking at me, I've been doing this for a while. I started doing antenatal classes, and Susanna Healy's The Confident Birth was one of the books that I used, and being able to give the partners the stroking skills and the voice skills and recognising when the women are starting to go rather than was one of the most powerful things that I had to use, and it was just brilliant. So to turn it into an app so that everybody gets to use it and the women can read it and use that information is just brilliant. Well done.
Thank you. Thank you. I can't take credit.
Okay, so it looks like we'll wrap up this session, but just as a final thought, you know, how interesting that although it's facilitating safety and managing complexity as our header, what all of these studies were showing was that actually the importance of pregnancy education. When the woman's informed, all the knowledge is given to her, she has full access to knowledge, the power is balanced, and then, you know, complexity and safety, or complexity is reduced and safety is enhanced. So thank you all so much for joining us today. Big round of applause for our speakers. Thank you.